two, one. So if we are live now, we can start our session. Over to you.
So, good afternoon, all the delegates. I welcome you on the behalf of Lupin in this webinar. Today, we have Dr. B.S. Hunjan for the webinar and very good, interesting topics on the hip replacement. But before we start the session, I would like to welcome and invite Mr. Partho Chakravarti, GM Sales and Marketing for the Pharma Division. So, sir, it is over to you.
Thank you, Ravinder. Good evening to all delegates as well as our speaker, Dr. B.S. Sunjan. And thanks for all of you to joining for today's ECME. And our speaker for today is Dr. B.S. Hunjan from Ludhiana. Welcome you, Dr. Hunjan.
Thank you.
Dr. Hunjan is a senior orthopedician with a rich experience more than 35 years with multiple international fellowships under his belt. Dr. Hunjan started his own hospital 20 years ago and performed more than 6,500 TKR and more than 6,000 THR till now. Thus, we are delighted to have Dr. Hunjan on board within us, and he will be discussing total hip replacement in acetabular bone defects. We look forward to an interactive sessions from all participants, and do post your queries which will be addressed by Dr. Hunjan at the end of the session. Thank you very much. Over to Dr. B.S. Hunjan.
So, thank you, delegates, and thank you, Ravinder Chaudhary. So now I welcome all the delegates, and we will be starting the session on THR and acetabular defects. So the most important thing in acetabular deficiency is that where is the deficiency and how to readdress that. Now, this can be because of the dysplasia or protrusio acetabuli. It can be because of the post-traumatic degenerative disease secondary to acetabular trauma and loosening of the acetabular component. Now, hemispherical cementless cups can be used in it, bilobed cups, high hip center, impaction grafting, bulk structure allograft, all these things we have to consider in this talk. How to go forward? Now, the goals of reconstruction are to restore the hip mechanism and re-establish the osseous cover of the new acetabular component which we put at the time of THR, and our aim is to get rigid fixation of the acetabular component and the graft be put in the space. Now, when we start the surgery, we go for the preoperative planning, and the planning is that we should take the X-rays in the AP and the lateral view of the hip, and one shoot through lateral view is very much because this tells us about the posterior column, which is often obscured by the cup on the other side, and Judith view, this also tells us about the pelvic discontinuity, and we can have 3D CT scans. This tells about the pattern of the acetabular defect and significant medial migration of the acetabular component. It is to evaluate the proximity of the neurovascular structures around the acetabulum, like especially the sciatic nerve. Now, magnetic resonance imaging is also helpful, and Mars MRI, that is the metal, this is the Mars MRI, which reduces the artifacts on the artifact reducing sequences, and then if there is osteolysis on MRI, it is seen in the low T1 signal and intermediate to highly increased T2 signal with a well-defined additional line of low signal surrounding the area of the marrow replacement. So these are the areas where we can see, and the role of the MRI, if you want to quantify the loss of bone, this is not a good tool to quantify the loss because CT is a good tool to have quantification of the bone loss, and metal on metal bearing THA, if it releases the metal ions, then this is a good tool to see the pseudotumor and metallosis. Now, this is one case where I'm going to show the acetabulum deficiency. This was a case of fracture, intracapsular fracture neck femur. It was fixed with 3 screws, and it ultimately went loose, went into non-union. The head was absorbed, and ultimately there is a deficiency of the acetabulum on the medial side. Now, this was ultimately done, and the mesh was put, and cemented THR was done with a long stem. Now, the classification of acetabular defects, it is very, very important to know, because if you know what is the classification and where we stand as far as the severity of bone loss is concerned, we can pre-plan the surgery, which cup or which graft and which thing you want to put at the time of surgery. So Proporosky has given us the best classification, and this classification tells us the severity of bone loss, ability to obtain the cementless fixation for the given bone loss pattern. And the key to this classification is the ability of the remaining host bone to provide initial stability, like hemispherical cementless acetabular component until ingrowth. Now, migration and what is the impact on the pelvis in the medial migration? This occurs in the anterior column, and grade 1 migration is if the migration is just lateral to the collar line. The collar line describes it starts from the ilium to the ischium. So ilioischial line is called the collar line if the migration is just lateral to the collar line, it is a grade 1, and if it is medial to the collar line, then this is the grade 3, and if it is on the collar line, and then it is a grade 2. And superior migration, the bone loss is in the acetabular dome, and it involves the anterior and the posterior columns. Now, superior and medial migration, if it is there, it involves the anterior column, and superior and lateral migration is there, it involves the posterior column. Now, osteolysis. Ischial osteolysis is there if it is the inferior migration or inferior aspect of the posterior column is involved, and it also includes the posterior wall of the acetabulum. And it is mild if it is less than 7 mm. It is severe if it is more than 15 mm. And about the teardrop, this number 3, you see the teardrop, and this osteolysis is inferior and medial aspect of the acetabulum. And moderate osteolysis, there is partial destruction of the teardrop with maintenance of the medial limb. Now, if it is severe, then there is complete obliteration of the teardrop. So you see these all things present. The number 1 shows the center of the hip migrating, and then ischial lysis, if it is number 2 is the teardrop ischial, and number 3 if it involves the teardrop, and then is the violation of the collars or ilioischial line. Now, this is the picture which depicts the Proporosky classification, and Proporosky has divided the whole bone loss into 3 categories, 1, 2, and 3. The 1 has only 1 grade, and the second type is divided into three, 2A, 2B, and 2C. And the 3 has got 2 grades and 3A and 3B. Now, type 1, here the acetabulum is nearly normal with some defects, and it has got contact rims are intact, walls are intact, and there is some bone loss on the inner side of the acetabulum, and anterior and posterior columns are intact. Acetabulum is hemispherical, there is no migration, and there is no osteolysis. So the acetabulum is ready to achieve the hemispherical cup. So there is not much difficulty in redressing this type of acetabular defect. Now in the type 2 is a hard, much more than this. This is the most common defect at the time of revision surgery, and if there is teardrop ischia, it's a very mild 0 to 7 mm, and average is 5 mm. Anterior and posterior columns are intact, and less than 70%, more than 70% host bone is intact with the hemispherical, which can give contact to the hemispherical cup. Now, type 2A, because I told you the Papritsky has divided the second category into three, 2A, 2B, and 2C. In the 2A, there is oval enlargement, superior bone lysis, superior rim of the acetabulum is intact, migration, the cavitary defect is evident medial to a thinned superior rim and is directed superior or superior spiromedially. And this migration is less than 2 centimeter. If it is more than 2 centimeter, then this goes into the stage 3. Now, some people say that it can be 3 centimeter, but most commonly we take it as 2 centimeter. And here also the treatment is we put some graft, particulate graft, and then we put the hemispherical cup. Now, Papritsky 2B, the superior astrial rim is missing, as you see in this case, and there is 1/3 circumference of the superior rim deficit, and defect is not contained. As you see here, the defect is not contained, it is eroded, and the remaining anterior and the posterior rims and the columns are supportive of the implant, because we can put the cup here and everything is intact. Now, the most of the reconstructions are done without grafting of the segmental defect. So here in this case, we can put the cup as it is, and occasionally an allograft, it is not supporting the implant. If it is not supporting, if the acetabulum is not supporting the cup, then some allograft can be put. Now, type 2C, there is medial wall defect in this case, and there is migration of the acetabular component medial to the Kohler's line. As I told you, the Kohler line is the ilioischial line, and here the cup has gone medially, and this is 2C. And the teardrop may be obliterated, and the rim is intact and will support a hemispherical component. Now, in this case, we can put the particulate bone graft medially on the medial wall, and this is just to do the lateralization of the hip center of the rotation and back to its anatomical position. Now, type 2 defect management. Normally, we use uncemented hemispherical cup in type 2 defect. It is used with the screws because we got a sufficient walls, and we can graft the defects, and structural allograft may be used to restore the bone. And now, medialization of the inner table of the acetabulum, how to do that? We can just expand the ream. We can use the expansion reamer, and true acetabulum is identified, and anterior posterior columns, till the interior and posterior columns are intact, we can just ream it, and we make the acetabulum hemispherical and then insert the trial. When we insert the trial, then we assess the bone loss, and structural allograft or porous metal augment can be put if it is not stable. Now, this is the procedure how we put the allograft in the where there is loss of the posterior wall of the and the medial wall of the acetabulum. This is how we take the head of the femur and fix it with the K wires. We can put the cancellous screws, or we can put a plate on the back so that the screws doesn't come into the way of the reaming. And finally, when the allograft is fixed, then we ream the allograft to make the cup hemispherical, to make the acetabulum hemispherical, so that we can put the this thing cup. So this is how we do it. Now, if there is superolateral defect, then these defects are very much less common, and seen most commonly in developmental deficiency of the hip, or dysplasia of the hip, and revision THA. It can be seen in revision THA or acetabular fracture cases. Now, this is how we do the address the. Now, sometimes we have to put the bilobed cup. This is the bilobed cup. The upper lobe is put into the defect, and the lower lobe supports the cup for the THR. And then 3A. In 3A, this is the more, you can say, loss is more in this case, and more than 3 centimeters superior migration is there, and moderate teardrop lysis is there, and collar line is intact in 3A. Now, you see the defect is superior here, and the remaining inferior columnar bone allows for about 50 to 60% of the host bone is contact, and the shell which we put in, it comes in contact about 50 to 60% of the host bone and gives good support. Now, this is the more than 1/3 or less than 2/5 acetabular rim is intact in this case, and the defect is normally from 6 o'clock, 10 o'clock to 2 o'clock, and ischial lysis is mild to moderate, not very much, and less than 15 mm inferior to the obturator line. And the trial components, they are partially stable in this defect, and normally we have to do structural allograft or augment. Now, this is how we put the allograft. This is the distal end of the femur. We divide it into two and fix it with the screws on the defect part, superior defect, and then ream it to make the cup hemispherical. Then we put in the implant. Now, 3V defect. 3V defect is the it's a outside defect, and we call it up and out defect. The columnar deficiencies have progressed to the greater severity, and the less than 50% of the host bone is available for contact in the shell, and may or may not have associated pelvic discontinuity. It can have pelvic discontinuity with it, and the entire acetabulum is now non-sportive or hemispherical cup. So we can't put hemispherical cup directly, and more than 3 centimeters superior migration and severe medial migration with the disruption of Kohler's line is there, or medial wall is also disrupted. So type 3B defect is the normally require acetabular cages. You see, this is the acetabular cage, and this is the augment which is you can say fixed to the cup. So to address the defect. Now, something about the acetabular cages. So the acetabular cage, where we should put, it is considered in large posterior segmental or combined defects. The principle of this is that we should be bridging an acetabular defect by anchoring the ilium with the ischium. Now, 5 to 7 centimeter of defect by means of proximal flange to the ilium and a distal nose to the ischium. Now, this red one is the cage. We fix the upper part of the cage to the ilium, and lower we put it in the ischium. We make a slot in the ischium and put the nose into the ischium. We can bend it with the benders, and then this is the put. Before that, I will tell you how we put it. Now, acetabular cup cage, first we ream the acetabulum, put the cup first, then if we see that the cup is not stable, then we put the cage. Now the cage fits into the cup which we have put, and the cage is fixed upper with the ilium and lower nose goes into the ischium. When we put the cup, then we make it with the osteotome, we make a slot into the ischium, and the nose of the cage goes into the ischium, and it fix in the ischium, and upper one we fix it with the screws into the ilium. And we can also do one thing is that this cage, we can put the screws through the cage, through a cage and the cup which we have put. We put the screws through the cage and the cup, and sometimes we obscure, we close the holes in the cup or in the cage with the bone wax so that there is no blood coming out. And then with the cement, we put the final cup. Though the cage must be adapted to the bone and the bone must be adapted to the implant. This is how we put the liner is cemented into the cage. So we put three things. One is the cup, then the cage, then liner. Now, next thing is non-custom acetabular cages. This has been studied by many people, and multiple failures have been encountered. Now, this is how we make the custom triflant acetabular component. So, what we do, we take the 3D CT reconstruction, and with the 3D reconstruction, we make the acetabular component. With this, it is helpful that we can get the holes where the bone is there. If we have got good ilium, we will have the hole for fixation in the ilium. If the ischium, we can get the hole for fixation in the ischium and ischium and in the pubic bone. So multiple fixations can be done, and then modular polyethylene liner can be inserted, and this screws while the acetabular defect is filled with the cancellous allograft. So what we do, we put some cancellous allograft, and then custom component is put into the acetabulum and it is fixed with the screws, so that because the screws are there only where the bone stock is there. So we put the this thing acetabulum component. Now this is how this is a custom component, this blue one, and this is how it fixes to the acetabulum and gives you proper acetabulum. But here we see the increased cost and delay in the surgery, because till the component comes, till then you have to wait, and cost is very much. So normally this thing is not used frequently. Now this thing then triflange THA, it has been done by Ginger et al. And they have seen that 54-month follow-up, and it is a quite successful surgery. 88.5% success rate has been achieved, and there were only 3 failures because of the loosening. Now, something about the pelvic discontinuity. Disruption of anterior and posterior column is there in pelvic discontinuity, and no one continuity is between the ilium and the ischium or the pubis. So non-sportive superior dome with more than 3 centimeter of migration of the cup is there. Now pelvic discontinuity, it is relatively rare. It occurs with the complicated reasons and poor outcomes. Increased in females because of the osteoporosis, 61 to 90% in RA cases. And management in this case, we can keep in hand the plates, cage, and everything. Operative exposure, the stress columns, if suspicious, then we can we should identify the discontinuity to the extent of the host bone, how much is the loss of the host bone. Now this is how we redress the pelvic discontinuity. Here the augment is used. We can use anything to fill the, like cage we can use. So anything which is fits, we can use it. The in pelvic discontinuity, this is the most difficult type of you can say defect, and difficult to address this. Now these are the various studies which has been done by the authors, and this is the algorithm which tells us what defect is there and what we should do. So basically, I understand that the major type of defects is the type 2 defects, and type 2 defects, hemispherical cup is the most common implant which addresses most of the problems. Now, thank you very much. This is all what I have to tell you. Now, the session is there for question answers. No, Dr. Chaudhary?
Yeah, sir. I'm just looking at the questions. So, sir, there is one question from Sanjeev Kumar.
Yes.
From Ramgarh. He's just asking, what are the common tips for acetabular reaming?
Now, while doing acetabulum, we must see how much bone is there. Sometimes I have seen that the reamers are so sharp that you destroy all the bone which is remaining inside. So we should be very, very careful while doing the reaming, and we should assess how much bone is there. That can be assessed with the help of, you can say, depth gauge or like that. And next thing is, we should ream there only where you see the actual acetabulum is. So try to avoid it so that the center of the hip may not go up or down. So try to keep the reamer in the direction with the proper anteversion and everything, so that you don't go in the wrong direction.
Okay, sir.
Next.
So the next question is, give your sir valuable opinion regarding how to solve the bone loss at calcar or neck of femur level. Although this is not related to the today's topic, but if you can give some opinion about it, it will be helpful.
No, if there is loss of calcar in the femur, then we can put the there are certain companies which are supplying the extra augment there, or we can put the custom prosthesis, mega prosthesis we can put, or long stem is a very good prosthesis. We can put the long stem prosthesis, and if the locking prosthesis is there, that will give us very much strong hold in the femur.
Okay, sir. And sir, this is one general question which come to the minds of the patient. So I'm just putting it in perspective. Like, sir, many patients, once they go for the replacement, whether it is knee or the hip, sir, what is the success rates they expect and they should expect while they are going for such kind of treatment?
So the primary hip replacement is 100% success.
Okay.
So unless the patient is very unlucky, the patient gets some infection or something like that. Otherwise, the success rate is 100%. If the surgeon is careful while doing the surgery, the success rate is quite a good amount. Good. So there is hardly any chance of going hither and thither, and no chance of that you will end up in the failure. But sometimes if the patient is unlucky, there can be certain fault at the surgery level, but normally there is nothing. Normally people go very well after the surgery.
Okay, sir. And sir, like from the patient perspective, once again, like what are the most common complications? Is there any effect or anything after the surgery which the patient faces and need to take care immediately after the hip replacement?
So after the hip replacement, there can be chances of fat embolism. Like you were trying to tell the thing, fat embolism. There can be, but in my life, I have never seen any fat embolism so far. If you make the patient ambulatory the next day and start moving the limb, then very, very less fat embolism or otherwise embolism occurs. There is very, very little chances, and patient responds very well to that. So no complications otherwise there. So the commonest complication, if you ask me, this can be the recurrent dislocation of the hip. Dislocation of the hip after you can say the rate is very, very less, maybe less than 1%. And this is just because there is some error in placing the cup or in placing the femoral component. There can be less anteversion in both, because we need to have combined anteversion of hip and the femur and the acetabulum to 40 degree. But sometimes there is very less. Femoral anteversion is very less, is the most common. So that can lead on to dislocation of the hip. And if even the acetabulum has got less antiversion, this can also lead on to dislocation. I have seen one case where the surgeon was very much conscious about the antiversion, and he put the antiversion of the acetabulum to 45 degree. It was so much that in spite of doing this THR from the posterior side, the dislocation was anterior. So that can also be happen. So, but normally these things not happen if the surgeon is a bit careful regarding the placement of the cup and the femur. So,
sir, this is the question, sir, which we have received.
okay.
And, anything, sir, from your experience, sir, if you just once again you can brief the things, and then after we can.
Yeah. My experience says that if you come across a patient, try to convince him that he should get the THR done at the earliest possible, so that there is minimum bone loss in future. Sometimes the patient says that there is very little pain, doesn't matter, I can go on like that. And when the patient turns up next, there is quite good amount of loss of bone in the either in the head of the femur or in the acetabulum. So we should convince the patient to go in for early THR, so that patient gets very good results.
Right.
And rest, if the patient is younger one, go in for cementless one. And if the patient is older, go in for cemented components. And this is all. Rest everyone knows. Then if the person is doing THR, they know these are the basic things which one should keep in mind.
Right. So thank you, sir. Thank you once again, for this insightful session, and also addressing the queries of all the audience. So thanks, sir. And I also thanks all the delegates pan-India for joining this session. Thank you so much. Have a great day. Thank you, sir.
Thank you. I also thank the company for putting me on the web, and I am very much delighted today. Thank you very much.
Thank you, sir.
Thank you.
So thank you so much. I'm ending the session now. Thank you.
Yeah.
Okay.